Good morning. It's lovely to see everyone here and to be in person and have this opportunity to share some of the research that is coming out of the Search for Diabetes in Youth cohort study. This is a really beautiful collaboration between Search and CHEAR that is finally coming to fruition. So I'm excited to share some of the initial results. So those of you that don't know, type 1 diabetes in youth is associated with premature cardiovascular disease. And there are a number of known contributors for development of cardiovascular disease in type 1 diabetes, including hyperglycemia, higher blood pressure, less favorable lipid profiles, longer disease duration and earlier age and onset, and then weight gain and adiposity. But despite the fact that we know what some of these known contributors are, efforts to mitigate this through glucose lowering therapies, lipid lowering therapies, blood pressure control, and lifestyle interventions really have demonstrated relatively modest impact on reducing risk for cardiovascular disease events and mortality. And then for youth onset type 2 diabetes, youth onset type 2 diabetes sadly is increasing in incidence and prevalence. And here from the today's study, they showed that there's this rapid increase in these very same risk factors for future cardiovascular disease events. This rapid increase in just 10 to 15 years in hypertension, dyslipidemia, and A1C values. And then from the Search study, this comparison of type 1 and type 2 and cardiovascular disease complications, we see in those first two columns there, yes, certainly for type 2, youth onset type 2 diabetes, a very high proportion with arterial stiffness and hypertension, even more so than our type 1 diabetes. But when you account for all of those sorts of known risk factors, there really is no difference between the two. And so there's a real need to identify novel biomarkers that can help us predict risk for cardiovascular disease, but even more importantly, help us identify factors that could serve as targets for mitigating this risk. So essentially, with metabolomics, we might be able to identify new pathomechanisms for development of cardiovascular disease. We might identify preclinical markers for future cardiovascular disease. And we might identify therapeutic targets to mitigate risk. So we had several aims as part of this Search CHEAR collaboration. Today, I'm just focusing on the second aim, but just know that part of our work will also include looking at PFAS exposures. So just a little bit of background about Search. Search was a study that extended from 2001 all the way to 2020. It actually recently ended. There were 4 funding phases for Search. It included both a surveillance component, and there were 5 Search sites that's presented here on this figure of the US, and it shows the catchment area for the different Search sites. But it was roughly 5 million youth each year that were part of that catchment population. It included complete ascertainment of all youth onset cases. Then a subset of those went on to form the Search cohort study. And for that, there were about 3,000 youth with diabetes that were followed either remotely or in person for a mean of 13 years. And when they would come in for that in-person visit, it was a comprehensive assessment of complications and comorbidities. And so this figure is just showing you the first 3 phases of Search, which informed some of the samples that were provided for the CHEAR collaboration. But you can see that we brought in Search cohort participants at different intervals throughout the different phases of Search. And then in Search 3 is where we had this comprehensive assessment of their complications. And so for CHEAR, this represented a subset of the Search participants that had both a baseline and a follow-up sample. And so baseline was within about 1 year of diagnosis, and follow-up was about 7 years from diagnosis. And they also had to have had in-person visits, and they had to have serum samples available. So we were biobanking these samples throughout the study. So we ended up with 898 cases of youth onset diabetes. Hold on just a second. And of those, after excluding those with missing covariates, we had 883. And then from those, 830 after removing outliers for the outcomes of interest. So we provided both baseline and follow-up serum samples for this untargeted metabolomics assessment. So that was quite a number of samples, and all of this happened. We provided the samples, I think, right at the beginning of the pandemic, and then everything sort of came to a grinding halt for a little while, and then it took a while to run all of those samples. But thankfully, that's all complete, and it's a really exciting opportunity. So the CVD associated risk factors were all from in-person study follow-up visits and using standardized study collection procedures, including waist to height ratio collection, triglycerides, LDL and HDL cholesterol, all of that was fasting, systolic and diastolic blood pressure Z-scores, arterial stiffness, which was ascertained from pulse wave velocity measured in the carotid femoral arterial segment with the SphygmoCor device, and then hemoglobin A1C. The metabolomics assessment was through assaying both helic positive and reverse phase negative modes, with the analyses limited to those that were identified or tagged. Metabolites with less than 50% detects were removed, and remaining metabolites with missing abundances were imputed by taking the minimum value divided by the square root of 2, which were then log 2 transformed, centered, and scaled. For the continuous outcomes, values were removed that were identified as the outliers, and if there was a right skew, the values were log 2 transformed. So for the helic positive mode, we had 36 named metabolites, and for the reverse phase negative mode, 46 metabolites. So there were a number of different analyses that were conducted. These were all conducted in Chris Ginning's group. But in step 1, it was primarily cross-sectional analysis of single metabolites being regressed on single outcomes. In step 2, principal component analysis was used to identify principal component 1 to summarize the overall risk of cardiovascular disease risk at follow-up and reduce our multiple comparisons. Then single metabolites at baseline and follow-up were regressed on PC1. And then next, a mixture analysis was conducted using repeated holdout random subset weighted quantile sum regression, which was applied to account for complex correlations and further reduce dimensionality. And then in the final secondary analysis, single metabolite secondary analysis of A1C and arterial stiffness, which wasn't represented in our PC1, was conducted. And here baseline metabolites were regressed on the A1C and arterial stiffness. All of the analyses adjusted for diabetes duration, age, sex, clinic, diabetes type, maximum parental education at baseline, and the sample collection year. So I'm going to provide a little bit of detail about the WQS method, although I'm going to tell you straight up, I'm not an expert in this method. And I think you'll learn more about that later in the conference. The weighted quantile sum regressions designed to account for the complex correlation pattern between exposures, here metabolites, and further reduce dimensionality of the exposure. So in our analysis, they randomly selected 40% of the participants into the training set to estimate weights and used the remaining 60% as a validation set to test the association of the weighted index on the outcome of interest. And then with the repeated holdout version of WQS, repeated this process of splitting the data 100 times, resulting in the distribution of effect estimates and weight estimates. And then ran the models assessing any associations in the positive direction and then in the negative direction to assess mixtures that may increase or serve as protective factors overall for cardiovascular risk. And if more than 97.5% of estimates were above or below the null, the association was considered statistically significant, and a metabolite weight contribution plot was constructed. So I'll show you those. When 90% of the weight contributions were above the threshold of concern, the specified metabolite was defined as a probable contributor of the mixture effect. And then when it was between 50 and 90% of weight contributions were greater than the threshold of concern, it was a possible contributor. So this is our sample. As you can see, it's a relatively diverse sample, but most of these kids at the time of diagnosis, the mean was almost 12 years. By the time we did that follow-up, they were closer to 18 years. Even split on sex, but about 15% self-identified as Black or African American, 15% is Hispanic, and then nearly 70% is white. Less than 50% had a bachelor's degree or more. And then you can see the distribution of the clinic sites. Our largest sites came from Colorado and Ohio and South Carolina. And most of these kids were type 1 diabetes, as you would expect. So this is the results from looking at single metabolites and principal component 1 at follow-up using the Helic positive mode. And so there's the baseline at the top and then the follow-up metabolites. And you can see that there's more metabolites at follow-up, which, you know, as I was thinking about this more, I was thinking, well, the temporality is such that, you know, potentially we're seeing more metabolites at follow-up because these processes are leading to some of these downstream metabolites. So highlighted in blue there is just where we observe the same metabolites at both baseline and follow-up. And then for looking at single metabolites and principal component 1 at follow-up using the reverse phase negative mode, again, we see many more metabolites identified at follow-up as compared to baseline. And just highlighted in red there are the ones that we observed in both modes, both the Helic positive and the reverse phase negative modes. And so here is some of the mixture analyses looking at baseline metabolites using the Helic positive mode with the positively constrained betas. And the left figure is just a plot of all of the different estimates. And then on the right is the plot of the WQS index plotted in a low S curve for the outcome of the PC1 adjusted. And so this indicated a significant mixture effect. So then we looked at the relative contribution of the individual metabolites to this mixture effect. And so the probable contributors here were uric acid, benzoic acid, and sphingosine. And so looking at the baseline mixture analysis for the negatively constrained betas, again, for the Helic positive mode, we don't actually see a significant mixture effect because 81 out of the 100 holdouts were below the null. So we had too many that were above the null. In the follow-up mixture analysis for Helic positive and the positively constrained beta coefficients, again, we see that significant mixture effect. And we see the relative contribution of the different metabolites for that mixture effect. So probable contributors here are uric acid, cysteine, proline, and gamma-linoleic acid. And then for our negative constrained betas for the follow-up mixture, we do see a significant mixture effect. And the probable contributors were glutamine, bilirubin, and dodecanoyl carnitine. It's a mouthful on that one. And now for the reverse phase mode, looking at the baseline mixture analysis in our positive constrained betas, we again see that significant mixture effect. and the probable contributors of tyrosine, phenylalanine, and uric acid. So you're probably starting to get an idea that uric acid is a major player here. And for the baseline mixture analysis, again, for the negative constrained betas, again, we see that significant mixture effect with potential protective factors being the glutamine and the dodecanoic acid. And then for follow-up, again, a significant mixture effect with aspartic acid, phenylalanine, uric acid, and xanthine as probable contributors. And then again, for the negatively constrained betas, at follow-up for the reverse phase mode, a significant mixture effect. And here, glutamine really comes out as the front runner as a possible protective factor. And so this table really sums it all up. So at the top, you have the baseline assessment and the follow-up assessment, the helic positive and the reverse phase negative modes, and then whether it was the single metabolite approach or the mixture effect approach. And what's interesting here, the blue boxes indicate the positive associations, the orange boxes indicate the negative associations, and the darker shading for probable contributors for the mixture effect analyses. But what's interesting to note here is that in some instances, a single metabolite was identified, but it was not observed in the mixture analysis approach. And similarly, there were some metabolites that were identified in the mixture analysis approach that were not identified in the single metabolite approach. But you can see here that the key factors where we really see this sort of consistency and response were uric acid, sphingamine, proline, lysine, and benzoic acid for positive factors, and glutamine as an inverse factor. So in conclusion, we observed this metabolomic signature for cardiovascular disease risk and youth onset diabetes from baseline and follow-up serum samples. The mixture methods identified metabolites not identified in the single metabolite approach. And we're hoping that this will be informative for future research evaluating therapeutic targets. For example, allopurinol for blocking uric acid, or it may inform mechanistic understanding of risk factors for developing cardiovascular disease and youth onset diabetes. So I'll just conclude quickly with acknowledging my collaborators, Donna DeBailey and Wei Peng at the University of Colorado, Dean Jones and Donghai Liang at Emory University, and Stephanie Busgang and Parita Ratnani and Chris Ginnings from Mount Sinai. And then the Search for Diabetes in Youth investigators and staff, families and youth from Search, and of course, the CHEAR here support for study assays in these analyses. Thank you.